Okay, well, thanks very much, and thanks y'all for having me. And just to start off, for those of you, many of you who don't know me or know our organization, we are a community health center. Yakima Neighborhood Health Services is first and foremost a community health center. We are in the Yakima Valley, which is about halfway between Spokane and Seattle. We have 9 primary care fixed sites across the valley. And we also have 3 resource centers that serve, everybody, but primarily we serve very low income people, and a majority of programs that we serve through our resource centers are people experiencing homelessness. We have contracts with our county government and our state government that provide consolidated homeless services for people that are looking for housing assistance, rental assistance, outreach services, and other just basic needs assistance like enrollment assistance, health insurance, childcare applications, and those kinds of things. The integration of housing and healthcare is really a daily part of our lives at Neighborhood. It's very near and dear to our hearts. And the integration can be much harder to do when people are without health coverage and other basic needs. So we work very hard to integrate all of our services. The picture that you see here is what I call our mothership. It's in downtown Yakima. We have 5 of our sites. Our primary care sites are in Yakima. And then the other 4 primary care sites are down the valley, which gets very rural. So Yakima has a population of about 100,000. And as you go down the valley, our other sites are in communities that are population 3,000, around 3,000 is the smallest site. And then the communities around that are even smaller. So we're both urban and rural. And in our rural communities, we don't have any public transportation. And so our outreach teams are really doing a lot of work out in the community. We saw about 25,000 people last year. And of those, almost half are agricultural workers, and about 15% are people experiencing homelessness. Everybody else, 90% of everybody else are, what I say is just plain poor. So they're living right on the edge. And so a lot of our services are really intended to try to bridge the gap. So next slide, please. So this year we will celebrate our 50th anniversary as a community health center. We have first applied for federal funding in 2005, so 30 years ago. So our first um, federal grant was in 2005, I should say 20 years ago. And so when we first became a Healthcare for the Homeless program, we had 2 drivers that really motivated us to the work that we're doing now. And the first one was we had a board member who started going out with our street outreach team, and he went out to the shelters and to the streets and everywhere with our team and doing focus groups with our unhoused populations, and to the shelters who are considered unhoused if you're familiar with the federal definitions by HUD. And the first thing that he was told was we need a place to be when we're sick, because at least in Washington, when you go to a shelter, you have to get up in the morning, usually 7 or 8 a.m., and typically leave. And so people that are sick, did not have a place to just sleep or to spend the day or to recover if they were ill. So he brought that back to the board, and the board said, well, that made sense, go out and figure this out. And so that's when I originally, I was charged, I was operations at the time, I was charged with figuring that out. And so I reached out to the National Healthcare for the Homeless Council and learned about medical respite. And that's how we started our journey in medical respite. The second thing that happened was about a year after that, our providers came to us. Our street outreach team became pretty adept at finding people out on the river, in our alleys, and bringing them in for healthcare. And our providers came to us and said, well, if you want us to make a difference in these people's healthcare, you need to help them put a roof over their head. And that started our journey into the world of permanent supportive housing. And it took us a lot of years, but 20 years later, we now have almost 200 units of permanent supportive housing. So these still, we consider these our North Star into terms of what we're trying to achieve in terms of improving the health of people experiencing homelessness. So next slide. So this is where we are today, and this continues to grow. You know, as we start to identify the barriers into working with our homeless populations, we've sort of put together what we call this honeycomb of services. Starts at the top. We are one of the largest coordinated entry providers. If you're familiar with coordinated entry in the world of HUD, in providing access and getting people prioritized for housing services. They do that at our resource centers. We also take those services out on the streets. And then our outreach program has many forms. I mean, we do have our street outreach team, our health outreach team are out on the streets, walking down by on the riverbanks and looking for folks, but we also have a variety of mobile units, and each of these mobile units have a different purpose. They're out looking for people. We have a primary care unit, which is the van in the middle, and then the van on the bottom is our hygiene unit. That neighborhood showers has three shower units in it, and that draws out a lot of people that are living unhoused, that are taking advantage of a place to shower. We see that as patient engagement because we have a fleet of community health workers that are there talking to people before and after the showers and trying to engage them into services. Medical respite is also a venue for outreach because oftentimes when people are feeling the worst, when they're sick or they're ill, that's when they often are willing to talk about coming in for services when they never did before. And then the other things around here, the health home program, which is for medically complex people, supportive housing and supported employment, our additional case management services that in our state, as part of our Medicaid waiver, are now reimbursable services. And we have an MOUD program that 47% this year of our patients in our MOUD program, our Suboxone program, are unhoused patients. And many of these folks start their MOUD induction in our medical respite program. So it's taken on a whole new value to our providers. And all of these are really centered around our primary care program because that's the heart of why we do what we do for our folks experiencing homelessness. Next slide. So this is what our program, our respite program looked like. We have a nurse-driven model, which means we don't typically do primary care in our medical respite programs. And part of the reason is that we have placed our respite programs within a block or two of our primary care sites. So within our respite program, we have a nurse, behavioral health, a case manager, and a housing specialist. And they are, as I said, within a block or two of our community health center sites. And so for the primary care, and also from a financial standpoint, and I'll explain that in a minute, that's where we have our primary care providers, medical, dental, the insurance navigators, our health home care coordinators and case managers, for the clinical side, and then our supportive housing and employment specialists. Those folks at the end, the housing and support specialists, they are much more mobile. They can go either way. The clients can go to them or they can go to the clients depending on what works best for the client. We have 3 sites now where we have medical respite, 2 standalone facilities, and then most recently, in one of our newest permanent supportive housing projects, we built in 4 medical respite units. So when somebody comes off the streets and they need a place to recover, we can put them into one of the respite units in our permanent supportive housing project because they get more intense services there. And then when they're recovered from there, they can go straight into permanent supportive housing in the new project, which is called Neighborhood Apartments. Next slide. And then this is what we do in our medical respite programs. So whether if they're coming from a primary care provider, the nurse will do an intake from the primary care provider, get the information from the provider, or if they're coming from the hospital, he, it could be our current outreach nurse is currently a male. He will go to the hospital and get the transition, get the transfer of care information while the patient is still at the hospital to make sure that we have the capacity to care for the patient, that they meet the standards so that it's not too much care that we can provide. The case management services, we do the daily health checks at least once a day, sometimes more. along with the case manager that's responsible for that. We have a behavioral health assessments and intervention that's driven by the nurse typically. We don't necessarily do that for everybody. The nurse will do a medication review and reconciliation. If there's wound care that's needed, that happens on a regular basis. And then the medical support, basically we build that into our call system that we have at our primary care clinics. And then we do assessment of social needs. We use the Prepare tool, if you're familiar with that, in all of our clinic system, and we do that on our clients in medical respite, just as we do in all of our other primary care systems. So the team is responsible then to assist with follow-up to the primary care and any specialty care that's been ordered, whether it's from the primary care provider or from the hospital provider at discharge. They also are looking at, the nurse then will determine any functional status needs, whether there are communication needs, if there are any cultural or ethnic factors related to either diet or religious practices or anything else that might impair or they need in order to recover. We also provide meals. We typically, at one point, we were contracting with aging and long-term care to provide Meals on Wheels, and that became cost prohibitive. So now we provide frozen meals so that they don't have to cook, but they have microwaves in all of their units. We provide and arrange the transportation, and then we're trying to facilitate any family unification. And then the minute they move in, we're starting to talk about, where are they going to go when they move out? And then one of our goals is to make sure that they have an ongoing relationship with the primary care provider when they're ready to leave. And again, and most of the time that's our primary care provider, but not always. If they have a primary care provider somewhere else in the community, then we want to just make sure that that's reinforced. Next slide. So this is an example. This is 2023. We haven't completed putting our 24 report yet, but this is a profile of why they came in 2023 into our respite program. So as you can see here, typically most patients are there for a week or less, and this is why. This explains the diagnoses on what qualified them for respite. And we until the pandemic we started our program in 2010, so we're just now almost 15 years into this, and before the pandemic our average length of stay was 19 days, and that had been true for the first 13 years. Since the pandemic, it's averaged close to 11 nights, just like it was in 2023. When we built our guidelines, we said that we wanted our standard to be considered 30 days or less. And we did that so that in HUD's eyes, that respite would be considered emergency shelter with medical oversight, so that when we exited someone from medical respite, we would not disqualify them from transitional housing or permanent supportive housing into a HUD-approved unit. We've certainly made exceptions, as you can see here. We've had people here for more than 4 weeks every year. We do, and we have the discretion to make those exceptions. But our standard is typically 30 days or less, so that when we find, if we have a permanent supportive housing unit that's funded by HUD to move them in, then we can do that. But this is pretty typical. And then since we started our MOUD program, every year we've had several patients that our primary care providers want to start on Suboxone, but they consider it pretty risky to have somebody on Suboxone still living on the streets. And so this is a much safer environment. And so this has been a successful alternative for them to be able to have the medical respite program as an option, and the support from the case manager and the nurse to be able to follow up with them. So next slide. So when we started our program, the majority of our referrals came from the hospital. And so our goal there was to prevent a readmission within 30 days. This is one of our goals, whether it's coming from a primary care provider or from the hospital. And we've really turned that around over the last several years so that our providers have a lot of confidence in our team. And now the majority of our referrals into respite are coming from the primary care providers. So we're preventing initial hospitalizations in the first place. So the chart used to look just the opposite of this. And so we really, really appreciate the fact that our primary care providers, their first call when it's safe is to the medical respite program. And we do have some referrals from community providers as well. But as the healthcare for the homeless um, site, the majority of the homeless in Yakima are cared for by our primary care providers. Next slide, please. So this is sort of what it looks like in terms of how where our expenses and our revenue come from. In Washington, we are just, our organization and one other in Washington has been piloting the Medicaid payment system in Washington for the last year. And starting this July, the Medicaid waiver is folding in Medicaid payments for all of the respite programs and getting payment through the managed care organizations. But this is what our expenses and payment system has looked like. And one of the things that, I think is just a reality is even when we have Medicaid being paid, it still doesn't cover all of the costs. So we still look to our other contracts to help us cover the costs of medical respite if you do it right. So, our staffing is 70% of the costs, and our overhead is not very high. And so you can see here where our expenses go. In terms of our patient population, the majority of our patients, 60%, are covered by Medicaid. And then we have a small portion on Medicare. And then we have, about a third of our patients are still uninsured. Next slide. And then this is just one of the things over the years that we have calculated when we talk to our managed care organizations as an example about getting their support in terms of our average costs and what it compared to the average cost in a hospital. And and then the other thing I think that's important is when we do have patients in the hospital, when we are discharging them, when we go to get them, we ask the discharge staff, if you didn't have respite care, how many extra days would you keep a patient in the hospital? And they give us a number, and then we calculate that to talk about, how much would this have cost the system? And we've done this every year almost since we started the program, because it's pretty meaningful to talk about how much medical respite care saves the system if we didn't have this available. Next slide. And then the other thing we look at is, how many people did we have to turn away? And so, this shows you that, well, almost half of them, the patient didn't qualify. And this is the hospital calling us saying they had people they wanted into respite, but these folks weren't homeless. And so we make sure to stay true to the mission of why we're here. There were people maybe that were living alone and fragile, or maybe they were too sick for a respite care, which is another concern because, we can only take who we can take. So they do have to be able to, if they had a home, recover at home. And maybe they needed actual skilled nursing care or nursing home care. Next slide. And then the last thing that we do is when we exit, we have a quick SurveyMonkey survey. This is part of our patient satisfaction that we ask people to complete every year, and just to make sure that we're doing things right or things that we could do better, that we get feedback from our clients. So that, I think, oh, real quick, I think there's two more slides that I just want to reference that might be helpful, questions that we get, is whether or not the patients are local. And most of the time, most of our patients are local. We do get requests from other parts of the state. So these are things to think about. We do have a residential manager. In the beginning, we didn't have a resident manager on site, and that became very problematic. And so if that's possible, I think you should think about that. When we didn't have a resident manager on site, they tended to invite their friends to come in and stay with them. That was really hard for people to recuperate. In the beginning, we did not have security or property management, and so that was a problem as well. And then things to think about was same-day surgeries became a need. All of a sudden, that was something we hadn't thought about. So we often get calls from same-day surgery centers saying, we have somebody that needs a knee replacement, and can you reserve a bed for them? So those were just considerations we hadn't thought about. And then the last slide is there's a link there that kind of gives you a tour. These are where our three different sites are. And if you're interested, you can click on that link when you have time, and it'll give you a kind of a walking tour of a slide that Annette, our homeless services officer, made with the National Healthcare for the Homeless Council that kind of gives you a visual insight of what our programs look like. So that's what I have to share. So thank you very much.
Great, thank you so much, Rhonda. I wanted to take a pause to see if anyone had any questions for Rhonda about our program. Feel free to come off mute or put it down in the chat and then I can read them out loud. All right, Teresa, put in the chat, how were you able to get case management paid for?
Well, in Washington, again, this is primarily through the Foundational Community Supports program as part of this. But because we're a Healthcare for the Homeless program, the case manager is really funded through our Bureau grant. That's the primary source of that service.
Great, thank you for that. Any other questions for Rhonda?
Is it okay if I just ask a question off mute? Okay. I am just curious, you mentioned the majority of your discharges, it sounds like, get discharged to permanent supportive housing. Are there folks that discharge back to shelter or street environments? Or could you speak a little more to like other discharge options that happen in your program?
Yeah, no, the majority right now, this year, the majority did not get discharged to housing because we don't have enough housing in Yakima. But those are tough decisions because we ask our primary care providers to tell us when their acute condition is resolved. And that's when they're ready for discharge. And so we try to find a destination. I think this last year was closer to like 30% we were able to discharge directly into housing. But the majority of them do not go into housing immediately. They may go back to the streets, they may go back into a shelter. When that happens, we do try to continue the case management services and stay in touch with them. We do get them into coordinated entry so that we don't lose touch with them, so that we can continue, so that we can try to find a placement, a PSH available for them when it's available. But, if we kept everybody in respite until we had housing, we'd never have enough respite.
That's still super impressive. 30% went to housing this year.
Yeah, well, thanks. So, I mean, we continue to try. And again, we've been fortunate in Washington. Our legislature has put a lot of money into additional supportive housing. And so we've gone from 100 to 200 units in the last 4 years. So, we probably aren't going to apply for anything in the next couple of years because we've got our hands full. But as a community and a couple of our partners are also building more homeless. And our niche in Yakima is really serving the chronically homeless. So they get prioritized pretty quickly because they have the most vulnerability. But it's still not enough. We still need more, like a lot of communities do.
Very well, thank you so much, Rhonda, for sharing that. Oh, We got one more question. Great program from Sean. Does government contracts equate to grant funding, mostly bulk sums or ongoing contracts?
Yeah, well, some of them have been recurring, not all. And it's, some of them have been like biannual because our state operates on a biennial, biannual contracts. So we do both county and state. We are very involved in our continuum of care. That's one thing I would say. And so when we first started, we went to our continuum of care and said, we have this grant from the Bureau of Primary Health Care, but we can't use it for leasing and meals and things like that. So if we provide the professional support, meaning the nurse and the case manager, could you provide the operations support for us? And our continuum of care did that for several years. And then one year they said, well, we're going to do something else this year. So then we had to scramble and we write some private foundation grants. We went to our State Department of Commerce. And so we've had a modge podge of ways that we have supported the operations. And then that's when we started getting involved with our managed care contracts. And so looking through patient fees and finding other ways to help support us. But we continue to use some of our Bureau grant funding because if you're involved with your grant funding, there is they call it, the Bureau calls it recuperative care. They don't necessarily call it medical respite, but recuperative care is the same as medical respite. So we're able to use some of our funds for that.
Great. Any other questions for Rhonda before I quick pass it over to our other speakers? All right, well, we'll loop back for more time for more questions at the end, but pass it over to Lisa and Bree to share their presentation.
I'm gonna just put my screen up real quick. Let's see. Can everyone see that just fine?
Yeah, looks good.
Cool. Awesome. Well, so I'm gonna probably bring us through the majority of the presentation, and then Bree's gonna come in on the back end just to share their participation in our program. So my name is Lisa Soroy. I'm the Director of Programs at the Poverello Center here in Missoula. So that is our emergency shelter for unhoused adults. I always like to share, our primary goal and focus is to provide food, shelter, help, and hope to all who ask. And our primary function is as a homeless shelter, as well as a food bank. So as you kind of can see here, we run a number of programs, but most relevant for today's presentation is that we do run a medical respite program in tandem with our primary focus of emergency shelter and soup kitchen and outreach and all the other programs on the screen. So what that looks like, before I go there, I always like to highlight, and I actually think it's great that we're kind of coming on after Rhonda did, because there are different models of medical respite care that exist in the country due to resources and funding and any number of reasons. And I think a couple of years ago now, we did some pilot work with NIMARC, which is the National Institute for Medical or Respite Care. I think I'm getting that right. Yeah. And they have been working on models to really help folks work towards kind of like certification of these programs to kind of give them a more robust name for themselves, because they have traditionally been really difficult to fund. But in that, we did some work with them to really go through this pre-certification process. So they don't have that process set up yet, but they're working towards it. And in that process, it became very clear that our respite program, which we knew is more of a coordinated care model, and I'll explain that here in a moment, what that really means, but that there are other tiers. So there's a coordinated clinical care, integrated clinical care, and then comprehensive clinical care. And I can't speak to Rhonda's program specifically, but it sounds like their program is a little bit more in that integrated or comprehensive, at least in compared to what we have to offer in our facility. And what that means is all med respite programs should hopefully aim to meet these key components. So, 24 access to a bed, access to meals, transportation, phone, safe space to store stuff, general wellness checks, as well as this like care coordination piece and case management, medical clinical care, kind of medication supportive management and behavioral health care. So when ideally anyways, when you hear about a respite program or you're seeking to start one, these are the facets that you're maybe gonna want to consider, and then identify like what this will look like for you. So an example being like the medication storage side. For us at the pub, what that means is we can, talk with patients or clients about what medication storage looks like for them, and maybe talk about utilizing those like pill counter containers and like figuring out tools and resources. But what it doesn't mean for us is like we cannot manage and administer those medications, but we can kind of do some health education on a basic level. So yeah, as you can see on the screen here, our model really is focusing on that individualized case management and facilitating those connections to community resources. That's kind of the biggest aspect of that work here. So it's one-on-one work. We do have and it's actually a 0.75 time medical respite care coordinator who runs this program. And she kind of does that one-on-one work with all of our respite clients, and then facilitates those community connections, and generally very much in coordination with our primary care, which is what Bree will help kind of elaborate on, or others in the community. And really, and we are also able to provide like that space where services could come in to meet with individuals if need be, but really we're like helping get to those community connections. So let me dive into the specifics here of our program. This is just a brief little, we offer privacy and time, ensure connection, and reduce costs on the local medical system. It's kind of, I think, at the core, that's often the goal of most med respite programs, is to do kind of these three things, and it just looks a little different in each location. And same, I'll highlight our program stats. We're similarly getting our 2024 stats together at this time. But as you can see, kind of similar to what Rhonda was sharing, but on a different scale. So I think the difference, one of the other differences here is we do have a pretty small program. So at any given time, we can have up to 8 individuals in our program. So our shelter, or our organization on a whole, probably serves up to 300 unhoused individuals on any given night. That fluctuates. So our respite program does run on that smaller scale of about 8 individuals. We have 2 semi-private units for men, and then 1 semi-private unit for people identifying as women. And then we have some flexibility in there as well within the facility to consider other opportunities at any given time. So with that, as you can see, in 2023, and most years, we're averaging about this like 60 to 65 number of individuals who were served by our program. Average length of stay is about 2 weeks, but same, it can be a couple days all the way up to a couple months. We really try to keep the stays that are a couple months to a minimum when possible, just because so we can keep space open for folks who need access to the program. However, we do work with our referrers or docs of the patients to talk about extensions and things like that. And that's usually when we start to see our longer stayers, is maybe they continue to have complications or need more time. And then to the best of our ability, we will try to serve them longer within the program. Similar to Rhonda, we really try to track like how many days does this reduce in the hospital? So we similarly ask that question on our referral. And with that, we do a little calculation to help identify like what projected medical savings costs are each year, just to really highlight the benefit of the program. And here in Missoula, our top referring agencies at this time are our 2 hospital facilities, and then Partnership Health Center, which is our federally qualified SQHE Health Center in town, so primary care. And we do, thankfully, we have opened up referrals over the years to really anyone in the community. So we do get some from like, same day surgery sites, different clinics throughout town. But those are just less frequent, due to a mixture of reasons. It's possible they might not know about our resource, or their referral might come from a hospital or partnership before it needs to come from that facility. And same thing, we have kind of some common reasons for referral. I always like to highlight, we really focus on that reality of an acute injury or illness. So, and where that does get difficult is so for folks who maybe have a cancer diagnosis, that alone might not allow us to say yes for respite, just due to the limitations of capacity and our just resources and ability to support folks. But maybe they have a complication related to that. An example is most recently we had someone who is dealing with MS, and they had a feeding tube inserted. And we were like, okay, we can't admit into our program just because of the cancer concern, but we can while you go through this acute change that is related to that larger diagnosis. And we do review each case. And really assess, like, is this the right environment for this individual? Because our program does operate out of our shelter facility, just on a different floor. So that does make it so we're limited in what we can really do, and we don't have dedicated nursing staff for this program. So let's see, I'm gonna branch over some thoughts over to Bree here in a second, and really why we felt it important for Bree and partnership to be part of this discussion is, while they are not a direct, they're not like on any contracts, or there's no official tie for our medical respite program. We do have a healthcare for the homeless clinic within our facility. That Partnership Health Center is the contractor who runs that program. And they're a huge resource. Like, we're able to just run downstairs and say, hey, can you tell me more about this clinical diagnosis that I, a social worker, know nothing about? And that can help us really determine, like, if we need to prioritize one referral over another, or think through different scenarios. It's a lot of benefit. So I'll pause. I think there's some stuff about funding that I didn't mention yet, but I can go back to that, and I'll give Bree a moment to kind of share her experience working with us. And then, I can share mine a little bit.
Awesome. Yeah, thanks for having me here. I'm excited to join because being part of the Poverello shelter and having my patients, the majority of the people who go into our respite program, or the Poverello's respite program, are also partnership patients, since we are like the dedicated place where people who are unhoused get their primary medical care. There are like a few people who don't get primary medical care through us, like veterans, or maybe they just had a previously established provider that they wanted to keep. But I would say the large majority of the people in respite are also our patients, and either referred by us or, like Lisa said, by the hospitals. And so being able to be on site and help coordinate their care has been really helpful. And the respite program, I have like actually seriously watched people's lives be saved because of the program on site. So very grateful for it. Like Lisa was saying, it's more of an acute service. And hearing about Rhonda's program, it was so amazing and cool to hear like how many different options there are elsewhere. Here in Missoula, we only have 30 permanent supportive housing units. And so that is definitely a very limited option on like housing patients here. There's a lot of barriers and challenges, as I'm sure there are everywhere. But for those people with more chronic issues, because there is no other place for them to go, it pushes primary care providers and hospitals to help get them to a higher level of care, like a skilled nursing facility. which is also limited here, as I'm sure it is many places as well, especially places that take Medicaid, which is what most of our patients' insurance plans are. But also we do have an IMAT program at Partnership. We don't utilize the Respite program a ton for IMAT, but we do have like inpatient facilities throughout Montana that help people with substance use disorder, and we'll prescribe Suboxone and have close follow-up where they follow up with our clinic at shelter often. The Poverello shelter, I'll let Lisa probably speak a little more exactly what the rules are if people are curious, but it is considered a dry shelter, so alcohol and drug use, patients can't utilize services if they're like not able to appropriately be in society. I guess that's a little difficult. The rules are a little bit yeah, Lisa, I don't know if you want to say something now or
Yeah, I'll just clarify it for you. It's more we really focus on behavior now, and we do run a couple of facilities in town just due to since the pandemic, there's been a lot of need for more space and other situations. So our emergency shelter facility, which we call Johnson Street, is what we call low barrier. Really allows folks to be intoxicated or just in more difficult dynamics. Whereas our Poverello shelter is really tries to work with folks more who are maybe using less, things like that. However, as an agency, we've really shifted to be more low barrier. I think maybe 5 to 10 years ago, we were, when you say dry, we were really like zero tolerance, no use. But we've really tried to change that up. But it does, just how our facility is built at the Poverello Center itself, there's a lot more like corners and places where you can't really see everyone. So we do have to be more mindful of what the behavioral outcomes could be if someone is under the influence. However, many people do come in and they're fine. As long as they're not causing issues with folks, we're all good to go.
Yeah. Yeah. And on that same note, like there are patients that we will refer to respite acutely, like if they had been off their mental health medications for a period of time. Like even if they, just to get them into a place where they are a bit more stabilized, but they're not needing that higher level of care stabilization in the hospital. So they're like not oriented to as many things like person or place, but they're able to like be safe for themselves or others. The respite program has been awesome, so we could restart the mental health medications and have a bit more closer follow-up. And that, so I guess that does go along with like substance use as well. We typically we prescribe Suboxone a lot at our clinic, and just have a lot of trust with the patients that we're doing that with, and they have a lot of close follow-up with our clinic. And I think like where the respite program like really, for me, I see a lot of success is like post-surgery or like during an infection when patients aren't able to be med compliant for whatever number of reasons that might be. Being able to have them in respite and having someone checking in with them and bringing them down to the clinic if they need daily medication administration or something, then our clinic can help provide that. And yeah, I think that is like super helpful in terms of us. And yeah, I guess I'll let you wrap up, Lisa, and then if anyone has questions, I can answer them later on.
Yeah, I don't really have much, and I can elaborate on like funding and other things, but I know we're kind of nearing time, so maybe I'll stop sharing so that way it can go back to the CHAMPS folks, and we can answer any questions that are coming up, so that way y'all, we can end on time.
All right,
I have a
thank you,
question
guys.
while you all are thinking about your questions. Bree, how many clinicians do you have at the clinic at the Poverello site? And are those full-time, or are you sharing that time with one of your other health center sites?
Yeah, so we are here 40 hours a week, Monday through Thursday, and I am the full-time nurse here, so I'm here all 4 of those days. And then we have like a front desk, PSR, patient service representative, who checks people in for appointments. And we have a provider that works here part-time, and we have a social worker that's here part-time, and a behavioral health therapist that's here 1 day a week. And those services are continuing to be expanded. And then there's multiple other clinics within Partnership Health Center. It sounds similar to like Rhonda. Within the few blocks, there are several other partnership clinics as well. But no one in partnership is working 24/7, or it's all like Monday through Friday business hours.
Does anyone have any other questions for our speakers? Yeah.
I think while we're waiting, I'll just share the funding piece, because I think it's important. Because so one part, or at least for folks who are maybe exploring, like trying this model, but obviously intimidated, we are really bare bones. So like I said, we only have 1.75 dedicated staff for this to run this program. Like technically I oversee her with that, but she is the main person. And for much of, I think we started it back in 2015, and for much of that time that hasn't changed. And we've had to utilize different grants and get creative and kind of just say, hey, we think this is important, so we're going to run it. Something recently in the past couple of years is we've been trying to do kind of like a fee for service model of sorts. So trying to work with our local hospitals to see if they can send any funds our way, kind of in that idea of, as we're able to take clients from the hospital who might have stayed longer, they're able to reimburse us a little bit for that service. We've only been successful with our local Providence Hospital, St. Patrick's Hospital. And currently it's just kind of a small trial that we're working on. So we kind of send them the numbers of referrals we've gotten from their facility each quarter. And then we do get a small reimbursement. But yeah, we are having to be creative with each passing year on how we fund the program. I think this year, for the first time, we also have some county funding. I think it's city or county. And yeah, just takes creativity and being open to trying the model with the resources you have as best as you can.
Thank you, Lisa, for that extra information. Anyone else have any other questions? Feel free to come off of mute or put them down in the chat. Well, I just had one more last quick question. For maybe some health centers that are hoping to get started with a respite care program, do you have any resources or maybe starting points for those health centers that they should look into? That's open for either folks.
I would just share, I think I shared a lot of their resources, but NIMARC, the National Institute for Medical Respite Care, they have a whole like toolkit on their website that kind of, says how do you do this, and has all the resources. I actually just got an email today that I think they're like pretty close to being able to pass their certification process, which is awesome, like actually make it legit. So I'm going to do some follow-up there, which is, I think, really good just for these models across the country going forward. And I know I was not a part of these conversations, but in the early days when our program really got off the ground, it was definitely a community effort. So like it was not just our shelter alone. We worked with different leaders across the community in the medical system, as well as, the city, county, things like that, to help give us some direction and move forward on this. And I would definitely encourage folks to find those allies in your community who see a service like this as a need, and get a little coalition together to see if you can make it work.
Well, I think Cindy still might be on the call, but they also have been doing learning collaboratives specifically for medical respite. And so, Cindy, if you're on the call, if you have any of those learning collaboratives happening, I know that they were very successful. You might jump in.
Yeah, absolutely. It's really good to be with you all today and to hear about all the exciting things going on there. We are super excited about all that's happening in medical respite. We have tons of medical respite resources at the National Healthcare for the Homeless Council, and NIMARC is an extension of our work. And so you see appreciate the person who put the link there. But we do have all kinds of things going on right now. We have things you can sign up for. Our national conference is in May, and there's going to be in Baltimore, and there's going to be a ton of information there about medical respite, whole sessions, a whole track devoted to medical respite. But yeah, if you go to our website, you'll see all kinds of things that have happened in the past and things that you can sign up for in the future. And then we also offer free technical assistance on medical respite. So any of this that you want to talk more about, please email us. We're happy to talk with you about funding and what communities have done that works and that doesn't, or to talk to you about all different kinds of things, partnerships with the medical community, partnership with the shelter community. We have resources like that too. So yes, please check out the website, but also feel free to email us and we can direct you to exactly what you're looking for. And we're happy to do that too. Very happy to talk more about medical respite.
And this is Rhonda again. I just wanted to say that I'm always so envious when I hear a program that gets some money from their local hospital. Our hospital loves us, but they never give us any money. So cheers to you all for being able to accomplish that.
Yeah, we have a really strong ally who was part of the early discussions of this program. And we're very thankful for it.